It's a real pleasure to be here and also share this virtual platform with the Mito Foundation, Professor Gorman and also Angela, who have been so wonderful in helping mitochondrial donation become a reality in Australia. And we very much hope that this is legalised very, very soon. I'm going to share my screen now and hope to show our slides. So as Alex said, I am a clinician scientist and I work here at Royal North Shore Hospital, and many of you on the line have actually visited our centre here. We have our clinic is in the back part of the hospital here and very, very close to our Colling Institute, which is the research institute which supports the activities of our clinic. And as has just been told, we've established it at North Shore Hospital for over the past 2 decades, and we now care for hundreds of patients across Australia with mitochondrial disease, and that's been enabled by telehealth clinics and extensions, with particularly funding from the Mito Foundation, which I'd like to acknowledge here. We're lucky we have 4 specialist doctors, a dedicated nurse and a research laboratory team that all work to help to improve the diagnosis, treatment and care for our mitochondrial patients. And you can see here shots from the clinic and also from our laboratory, which is located at North Shore Hospital. So I'm going to talk to you a little bit today about what the patient's point of view is when they go through our clinic, and also what the promise of mitochondrial donation can provide them. So remember, as Professor Gorman mentioned, that there are mitochondrial diseases that are caused by mitochondrial DNA and also nuclear DNA. Most of the chromosomes here are in the nucleus, in this picture of the cell, and all of the genes come from this nuclear DNA. But what we're talking about today is mitochondrial disease that is caused by mitochondrial DNA mutations. And this bit of DNA is from the mitochondrion and is represented by this double ring structure. And all of this comes from the mother. This is just a little cartoon of all of the mutations. There's over 250 mutations that are associated with mitochondrial disease, represented here, and really right through the double ring structure of this bit of DNA that that we're talking about today. Now, as Grania said, at conception, all mitochondrial DNA is derived from the mother's egg. The mitochondrial DNA in the sperm is destroyed during the development, as she said. And this means that all children of an affected mother with a mitochondrial DNA mutation will inherit the mitochondrial DNA mutation and are at risk of developing mitochondrial disease. And this is shown in this picture here. This is actually the family tree of one of the first families that I studied when I was doing my thesis on mitochondrial disease. And this is the patient, or the first person that came to the hospital presenting with a stroke. And you can see all of the children of an affected mother are affected here. You can see the grandmother and all of her 3 children are affected. But of course, whilst the mothers have affected children, the squares, which are detect males, the children of affected males aren't at risk at all. But we know then that when a patient comes and they have they're female and they want to have a family, we know that there is a risk that all of their children are at risk of developing the disease. And so many potential mothers come to the clinic and say, well, what is the risk of my child being affected, or my unborn child being affected? And this really depends on a number of different factors, which we go through in the clinic. How much DNA mutation you might have. We refer to this scientifically as heteroplasmy. I'll talk to you a little bit about this. It also depends on what specific mitochondrial DNA mutation you might have. And it also depends on what we refer to as the mitochondrial genetic bottleneck. That is, how much mutation is in the mother's eggs or ova. And I'm going to leave this part, that final part, to the next speaker, Susan Savolt, who will be talking a little bit more about that. But just to show you what happens in our clinic, this is the sort of discussion that we have with our patients. You can see here that in normal patients, this figure shows that in normal people, mitochondrial DNA is usually identical amongst all of the mitochondria within the cell. And we call that homoplasmy. And it's depicted here as little green mitochondria, which have identical normal copies of mitochondrial DNA. But in patients with mitochondrial disease that have a mitochondrial DNA mutation, the mitochondrial DNA mutation is often present in the cells which coexists with the normal mitochondrial DNA. And we refer to this as heteroplasmy. That is a coexistence of normal and abnormal mitochondrial DNA within the cell. And every time that cell divides, then the daughter cells may either have a mixture of of abnormal and normal mitochondrial DNA. They may have much abnormal DNA, or they might have all normal DNA. It depends on which way the cell divides. Now, because mitochondria are in every cell in the body, almost every cell in the body, they're not in red blood cells, but pretty much are in every other tissue of the body. As a general rule, the more mitochondrial DNA mutation you have in your tissue, the more symptoms that you have. And if it's in the muscle, for example, you might have muscle weakness, fatigue. If it's in the heart, you might have some heart troubles with some weakness of the heart or abnormal rhythms of the heart. And if it's in the brain, you might have seizures or strokes or jerking movements or migraines, and so forth for every other part of the body. I'm going to show you a couple of clinical scenarios that happen that occur when patients come to the clinic, and just so that you can actually understand some of the problems that our patients face, and then understand what the promise of mitochondrial donation might bring. Now, here's a little case scenario where a 24-year-old female came to the clinic. We represent females with circles and men as squares. This is the patient here, and when she came to the clinic, she knew that her mother was well and that she had had a low mutational load. In this case, the family had 3243. It's located in this part of the genome here, and this is one of the more common mitochondrial DNA mutations out there in the community. Our study showed that this is present in 1 in 500 Australian people in the community. And when this patient came to the clinic, whilst her mother had a low mutational load, her brother had MELAS syndrome, and he had 25% mutation in his blood at the time. He was at 19 when he first developed symptoms. And of course, she had another sibling who was not a patient at the clinic and didn't come to the clinic. And she asked us, what is the risk of mito in her if she were to have a child? Of course, this is difficult to say, right? Because you can imagine that because she has a low mutational load, that her risk will be low. But so true for her mother as well, who, as you can see, had a son who had MELAS syndrome, a severe mitochondrial disease. Now, I like to just quote this study. Of course, it's from Gronya's own research group. And if one were to predict that measuring mitochondrial DNA mutational load, you might sort of think that the higher the mutational load, the lower the chance you have of having a child free of disease. And if you had a low mutational load, you might have a better chance of having a child without clinical disease. And so that's represented by this line here. But when Gronya's group measured the actual amounts of mitochondrial DNA that were in mothers and children pairs, both from the literature and from their own group, they found that there was actually no correlation between the amount of mutation that was passed on to the children from the affected mothers. And so we now know, particularly for this mutation, that the amount of mutation in the mother does not predict how much mutation is going to be in the child. Here's another case scenario, and again, Granya's already mentioned about Leber's hereditary optic neuropathy. This family had the mutation 11778, again located here, over here in this part of the mitochondrial DNA. You don't need to memorize that, but suffice to say that this female came again to the clinic knowing that her brother had had Leber's hereditary optic neuropathy. Now, you might know that with Leber's hereditary optic neuropathy, as Professor Gorman already referred to, you have high amounts of mutation should you have the disease. But in fact, even if you have high amounts of mutation, it doesn't necessarily mean that you get the disease. In fact, males who have this mutation, even if they have 100% mutational load, only have up to 50% chance of having this disease along their lifespan. And so this patient's mother also was a carrier, but she was well. Again, she had a sibling. We don't know what they had clinically, but the question was from this female: what is the risk of passing on mitochondrial disease to my children? And again, this is a challenge that is faced by these families. And finally, just to illustrate again the point and to underpin the point about how complex this can be in the clinic, we have another female, same sort of situation. This time the family has Murph syndrome, which is again caused by this mutation here. 8344 is the numbers depicting the place in the mitochondrial genome. And again, this female patient, again, well, has a brother with Murph syndrome, and has a mother, again, very, very mild disease, mild hearing loss with a mutation load of 55% here. And she asked, what is the risk of mitochondrial disease in my children? And with this mutation, the higher the mutational load, the greater the risk of having symptoms, and the greater the risk of having severe symptoms. So again, it depends on what specific mutation you have as to what the clinical advice and what the risk might be for each individual family. So we take all of these things into account, and like Grania referred to in her own clinic, we talk about various different reproductive options for patients that have mitochondrial DNA-related mitochondrial disease. And so, of course, some of the reproductive options include voluntarily deciding not to have your own biological children. This can also include adopting children, very difficult in Australia with the limitations that are available to, and the availability of access to adopted children. Donor egg, also, again, this needs to be not from a maternal relative because of the same chances of having mitochondrial DNA mutation in those donor eggs. And so access is challenging at least in Australia because of the limited availability of donor eggs. Some choose to fall pregnant naturally and take on the risk of having a child with mitochondrial disease. And others choose to undergo pre-implantation genetic diagnosis with the possibility of selecting eggs with less risk. And again, Susan Savant will talk about this process in more detail in the talk after this one. And finally, coming into a possibility with the work that Angela Albrecht has referred to from the government, the mitochondrial donation, which, as you've already heard, replace the mitochondria, the faulty mitochondria, and reduce that amount of mitochondrial DNA mutation that is passed on to the child from the mother. So all of these options are possible to have, and these are the challenges and the considerations that a patient with mitochondrial DNA needs to consider when they come to our clinic. Again, I refer to this care pathway that has been published by Grania's group, where there is quite a lengthy procedure, integrated care, as Grania said, and multidisciplinary sort of teams being coordinated, considering many, many different aspects along this pathway as we can support families who want to have their own children who are affected by mitochondrial disease. And I was very, very lucky to visit Grania's centre over in the Newcastle, and they are very kindly supporting our aims to set up such a clinic as we plan to establish a reproductive advice clinic at North Shore Hospital. So finally, just to summarise what I've talked about today, the risk of having a child with mitochondrial disease caused by genetic mutations in mitochondrial DNA depends on many different factors, including what specific mutation you have and the amount of mutation you have. The reproductive options such as mitochondrial donation can reduce the amount of mitochondrial DNA that is passed on from mother to child. And mitochondrial donation provides the best hope at the moment that affected families with mitochondrial DNA mutations can have to have a biologically related child with lower or no amounts of mitochondrial DNA and lower the risk of having severe disease. And a final point, take-home message, that the mitochondrial clinicians can provide this expert advice that is needed to assess and help patients with the decision-making by integrating and collecting and assessing all of that information and guiding our patients through the whole process. So I might leave